Welcome to UBC Department of Emergency Medicine Grand Rounds for our first one for the academic year. And it is a big day today. September the 12th is the first anniversary of the Emergency Medicine Network. So we've had a lot of successes. We're not here to talk about that, but just a nod to the network and what it's been able to do over the next year and hopefully for success in the future. And now, we're really privileged to have Eric Grafstein come and present the first rounds of the year. He was very excited to step up and take on this role. I think you all probably know Eric, but Eric has been often a quiet but an incredibly important part of our academic department. And we go way back from developing the research program at St. Paul's. But Eric's always had this burning interest in data, and we're very lucky that in this age of transformation into new electronic systems that we've had somebody with Eric's emotional intelligence and clinical wisdom to be actually in the middle of that mix and that transformation so the whole system doesn't get run by IT people who don't know what patients are. And so Eric's here to talk about it because it is a big change. As we move to these things, there's huge benefits for this. And he spent a lot of time trying to figure out how we can do this as seamlessly as possible and change the clinical environment to be more supported electronically. Is all of that right, what I just said?
Everything is good.
Hand it over to you. Thanks very much, Eric.
Jim, thanks very much, and thank you, everybody, for the chance to share some of the experiences that we've had so far with the Cerner implementation at Lionsgate and Squamish. As Jim said, I have a role both as the regional ED head, and I'm also the Chief Medical Information Officer. So when we went live at Lionsgate, that was kind of where the Venn diagrams overlap, and tremendous opportunity for me to fail twice with one project or to succeed twice with one project. Maybe I'll let you judge at the end. But I'm going to there's a lot of noise out there about what happens when you go live, and I really just want to talk about that in the context of this implementation. Talk a little bit about EHRs, electronic health records, what the literature says, and talk about the factors that made the go live successful. And maybe if there's time, I will give you a little demo. That's always good because when the quasi-technical person does the technical demonstration, you can be sure that it won't go right. Right, so I just want to start with the why. Why are we doing this project? And you all know this, that this is one of the CSD posters that talks about the reasons for doing the project, but there was an article in the CMAJ in 2004, the Baker-Norton report, that based on some evidence from a few hospitals, they extrapolated that we're up to 24,000 deaths a year in Canadian hospitals due to adverse outcomes. And what that says is we've taken paper and pencil as far as we can take it, and that really the only way forward to try and reduce those is using another way. And that's an electronic health record that might have checks and balances that help you. Other things that are really important, and what's different from when I started to practice, there was an X-ray machine. People got an X-ray. Maybe they went to get an angiogram, sort of. Now people have PET scans and MRIs. They go all over the province to get their care. There are specialized centers. And the ability to kind of curate that information into one spot where you as a provider can know it, that's impossible when you're writing things out by hand. I still it hasn't happened recently, but I can remember in the sort of not too distant past where I'd order a CT scan on someone's head and I'd get a report back that said, compared to the CT scan done last week, there's no change. And I think, God, why didn't I know that person had a CT scan of their head? What a waste of resources. I should have done better. The systems help you do better. And lastly, there's a legibility and a translation of information and clinical decision support. I was working at VGH a few weeks ago, and this could have happened anywhere, but it just was where I was working, that the nurse in handover told her colleague that the patient was supposed to get bisacodyl, 20 milligrams, and the 90-year-old patient got bisoprolol 20 milligrams. And, that doesn't happen when you're barcode scanning meds. There are other things that happen in an electronic health record, but in totality, these are some of the reasons why we have to move forward. And I think because you're all here, and I don't see anybody with tomatoes just yet, that I think most of you have bought into that, and almost everybody does. Canada is probably one of the few first world countries where we don't have an electronic health record. And so it's time we do it. These are the most popular systems out there. Epic, Alberta is going with Epic. Allscripts is a system that's been employed here. Of course, Cerner Meditech is what's being used in Fraser Health. And I'm here to tell you that there is no one that is particularly better than the other ones. There are the factors that we're going to talk about, the factors that make implementation good. The system you use doesn't matter. And in fact, this is probably true. The system that you hate is the one you have. The system you love is the one you don't have. And so, Cerner actually happens to be a very sophisticated product. It isn't a bad choice, and there's lots of reasons to like it, and there's a few to hate it too. So I'm really now going to talk about Go Live and what that's all about. And, it's such a huge change to go from writing to an electronic health record. And that creates challenges. And the two things that we want to do when we support a site that goes live is we want to create this cognitive bandwidth so that physicians can learn how to do things. And we saw in other places that have gone live where there wasn't this cognitive bandwidth, that physicians are scrambling and they don't really learn to do things the right way. They learn a way, but it may not be the most efficient way. And once they do it for a really long time, it's hard to change. And then they have this permanent inefficiency. And of course, I mentioned it second, but patient safety, right? If you're going from a 2% left without being seen rate to a 7 or 8% left without being seen rate, and your time to physician climbs from an hour to 8 hours, the patients are at risk. And so there's an imperative in healthcare for us to do the right thing for our patients. And that actually is scary because, as I said, the change is big. So those are the two guardrails. And within those two guardrails, we have lots of room to do stuff. You'll see what we did. So this graph, the process of transition, and you can see the so-called valley of despair, which is about a 3-month period, sometimes 4, that happens after Go Live. And
Code white, Gerard, level 1, main hallway. Code white, Gerard, level 1, main hallway.
Okay. And so
White, Gerard, level 1, main
the
hallway.
goal of the implementation is to kind of make that valley as narrow as possible and as shallow as possible. And what this really says is it identifies that, yes, there's loss of productivity at Go Live. People think that the electronic health record is going to be their iPhone, and it's not. It's more complex than that because you are the only one using your iPhone, but there are hundreds of people using the healthcare system at the same time you are, the electronic health record. There are nurses and registration clerks and pharmacists and lab tech, ECG. And it's a really complex system. But the good news is you get to the other side, and if you notice in this graph, they actually are above where they were before, and I think that is probably true. So, one of the things, because at the outset of this project, there was a lot of concern by a lot of physicians, not just in emergency medicine, but everywhere, that they weren't going to do as well as they did before. So I reviewed the literature as best I could. I used terms like efficiency in electronic health record and looked at some 500 articles. And I tried to focus on the most recent ones, right? Because just like you wouldn't be looking at a 1970 New England Journal of Medicine article to look at how you're going to practice medicine today, electronic health records from 15 or 20 years ago are not the same as the ones now. And so that literature is not necessarily as helpful to us. So just to summarize, the literature does not point to an advantage of one system over another. And I was struck by the fact that there were really mostly success stories. And, you know, I guess I can understand that. No one wants to say, guess what? We implemented a solution and it sucked and everybody hated it. You know, newsflash. I mean, that's not the kind of article that people submit. I get that. So there's probably a publication bias. In the States, EMR is what we would call EHR, but I use the term EMR to refer to a single closed system that is used in a doctor's office, whereas EHR is this integrated solution that has radiology and lab and pharmacy and acute care and emergency medicine all rolled into one. And office systems, most GPs, specialists love their office systems, and it's easy because it's all you're really doing in it is dictating. You're bringing in some information, but you're not ordering things. You're not. There's no one who's giving the medication and making sure that the medication that the patient's doesn't have an allergy and all that kind of stuff. So the articles that talk about office EMRs, they're generally favorable, and we have to be careful not to think of, you know, that's not exactly what I was looking for. Because, as I said, hospital EMRs have more complex technology. Right, so we talked a bit about the older articles. And then another thing is there's a lot of stuff about burnout and how the systems are horrible. And a lot of that literature evolves from the States. And to be honest, the States have this meaningful use thing, meaningless use. And the medical legal realities. And in my more cynical times, I think that the electronic health record in the States is really a billing system that, as a byproduct, allows you to look after patients. There's so many requirements that you need to make sure that insurance companies will accept your billing, that they're designed in a way that is irritating as heck for providers. And to be honest, most of the design work we did was strip away the American out of the electronic health record so that it would fit our needs. There definitely is a loss of efficiency at go live, and this can last weeks to months. The literature talks about that, and the experience in Nanaimo also identified this as well. London, Ontario, same thing. So that was important for us, and it shaped how we thought about what we would do at go live. But in the end, most sites say that productivity is the same or slightly higher or a little bit worse. I mean, things end up being about the same. So what is there in the and specifically regarding emergency medicine literature? This retrospective chart review in the American Journal of Emergency Medicine. So their system, they went from paper to what they called an EMR. And again, I don't know if I can't remember what the solution was. I don't believe in the article they say what the solution was. But they looked at the total ED length of stay and the left without being seen rates or left against medical advice rates. They took 3 months before go live and took 3 month snapshots for up to 18 months. And in the end, they thought there was minimal impact on efficiency and workflow in their ED. I don't know if any of you know Chris Fernandez, who is in London and was part of this study. And what they implemented Cerner, don't worry about reading it, I have this summary. But they implemented Cerner in about 2013. And then they implemented it in a very different way than we did. They had they had elbow support that lasted a couple of weeks. They didn't really upstaff. They actually didn't do electronic documentation. And they focused their article, they wrote an article to talk about how their implementation gave them worse results. And they compared the first 3 months after go live with the 3 month period the year before. And from what I've told you, the first 3 months can be a bit rocky, and I thought that wasn't necessarily a fair comparison, but they did document that this, early post go live, their admitted patients were staying an hour longer in their ED, And I thought they had even though it was statistically significant, I thought they had a clinically insignificant increase in time to MD by 5 minutes overall, and their overall ED length of stay increased by 10 minutes, and their left without being seen rate increased by less than 1%. So this was an article that kind of balances and says, things can go awry. There's some articles that talk about how long you should support and whether or not you should support. So this article from Western Journal of Medicine talked about, said it would be wise to increase staffing for the first 2 to 3 weeks in your ED. And again, that was, I thought, thoughtful comment. And so what did we do at LGH? So we have this background. We know that things end up okay, but productivity goes down initially. And how should we support the emergency physicians there? Well, first of all, as an organization, there was a decrease in surgery that started a week before, down by 50%. The first week after go live, down by 50%, and then the next week down by 25%. Some of that is just because their workflows are complex, more complex in many ways than the ED, and they need the bandwidth, the same issues. They need time for the nurses and the physicians to get used to doing things a different way. But that has a benefit to the ED because less surgeries means less admitted patients, less elective admissions, and so the flow in the hospital is a little bit better. And that's an important concept. Operational flow and efficiency needs to be good when you go live. We had a repatriation strategy that I'll talk about, ambulance diversion, and regional kind of diversion strategy. We tried to make sure that we could divert people from coming to the ED. I'll talk about upstaffing and elbow support. So the repatriation strategy is, again, this is all about increasing inpatient flow. And so if Lionsgate had sent someone to St. Paul's or VGH for, let's say, bypass or definitive care, traditionally they would be sent back as soon as the procedure was over. But during this 2-week go-live period, you got our patients, you keep our patients, you discharge our patients. Likewise, if they had a coastal patient at Lionsgate that was admitted and they needed to send them back, they just sent them back. And there was an agreement that sites would repatriate their patients. Again, small benefit to the ED, but important because it means that patients that need to be admitted are unlikely to linger in the ED, and it decreases overall efficiency. And I think in the first week in go live, Lionsgate was at about 60% capacity. It was really impressive, all the things that were able to be done to make the organization not too stressed under the strain of learning this new system. So in terms of ambulance diversion, I thought about this is the Monroe-Kelly doctrine that talks about intracranial pressure versus volume of stuff in your brain, and how you can auto-regulate for a while, and then at some point, when there's too much blood from your subdural or epidural, you can't auto-regulate the intracranial pressure, and things go haywire. And it strikes me that the ED is like this a lot. In fact, all hospital systems are like this. We tolerate increased volume for a period of time, and then all of a sudden the wheels fall off. And actually, Les Vertesi showed a very similar graph yesterday at the section of emergency medicine meeting when he was talking about queuing theory and how he did his modeling for the rule to provide additional staffing for the APP contract. So to me, what this suggests is that we didn't need to change the number of ambulances arriving at Lionsgate ED very much in a day, or the number of admits very much in a day, to have a profound effect on the organization. So we created these criteria for the ambulance crews. Has the patient that they're seeing on the North Shore, have they had treatment at Lionsgate recently? Or are they getting ongoing treatment at Lionsgate? Is their acuity high? If the answer is no, we ask the crews to suggest that they take the patients elsewhere. And we even arranged that the patients, if they were taken elsewhere, we would give them a taxi voucher to get them home again, because only about half of them require admission. And we divided we did some modeling based on the ED data, and we divided the North Shore into kind of 3 zones. The gray zone, those patients if they were willing, would go to St. Paul's. The zone in the middle, which is right, and the star kind of shows you where Lionsgate is. It didn't seem reasonable to ask those patients that live 5 minutes a walk from the hospital to go somewhere else. So those patients were going to go to Lionsgate. And Neil Barkley and Sheila Fenimore from Fraser Health were very helpful, and they agreed that Burnaby Hospital would take some of the patients in the green zone. And not surprised, it may be surprising to you that Burnaby is really the closest hospital in the Lower Mainland to Lionsgate, and it only takes about 10 minutes to get there. So the idea was, we thought that we could reduce carries by about a third, by about 12 ambulances a day. We thought that about 8 would go to Providence Healthcare or Vancouver Coastal Health, and 4 would go to Burnaby, and that since you get about 1 admission for every 2 ambulances, we were looking at about 4 less admits a day. We in terms of trying to mitigate walk-in traffic, there is the ED Wait Times website, www.edwaittimes.ca. I use it a lot before I come into shift to kind of gird my loins. And you should know that we had our 1,000,000th hit earlier this year. I thought that was impressive. You might not be able to read this red banner here. Lionsgate Hospital is installing a new computer system. Emergency wait times to see a physician may be increased in the weeks following the installation as physicians and staff adjust to the change. So that's not the message that I wanted. I wanted something that said, unless you're dying, don't go there, or something like that. But I was shot down. And it's interesting to see the impact of walk-in traffic as well. So the other thing that happened was that there was significant upstaffing to Lionsgate. So 30% reduction in productivity meant that it seems logical. We should increase staffing by 30% to overcome that. So for the first week, there were 3 extra shifts. In the second through 4th week, there were 2 extra shifts, so 20% increase. And then for the second month of go live, weeks 5 through 8, 1 extra shift, 10% increase. And again, other places in Ontario that have gone live with Big Bang, like Nanaimo, had 1 shift sort of belatedly or not at all. And I think this alone would have been enough to help get the hospital over the hump. And it was really important. And then the last thing we did, which is what is recommended at all sites, is to have this elbow support. So I use the driver's ed analogy, right? When you have taken your course and you read the book and do the whatever, you know nothing, but you know where the ignition is and you know where the turn signal is. You need the driving instructor with you as you take the car on the road. So we had people, some from Cerner, some from Nanaimo. We had emergency physicians there. Drew Digney was one of them. He was awesome. So was their 3 ACMIOs came over, Andre DeWitt and Lon Moronic and Willie Puarchuk. They were very helpful. And then through some connections that I had made previously, we had some physicians from Cornwall. They were awesome. And some LA County physicians who came to support the Go Live as well. These other sites, of course, are on Cerner as well. And there's something about talking to another physician, especially another Canadian one, that is helpful. Okay, so what happened? So I have a couple of graphs. The blue bar, so this is the 2-week period around the same Go Live time from the previous year. And then these 3 periods here, the month before Go Live, the 2 weeks just around Go Live, and then the 6 weeks afterwards. So if you look at ambulance volumes, in the previous year, there was 31. In the month before, there were an average of 30 a day. During the 2 weeks of Go Live, there were an average of 23 a day. And then in the 6 weeks after that, 33 a day. So I was pretty happy with that. I think that kind of demonstrates a real impact. Admits, 25 in the year before, 25 in the month before, and an average of 20 a day through the ED, and that bounced back to 24. Again, significant. And volumes, the year before 177 in the peri-go live, what would be the peri-go live period, and then in the month before 173, 170 during go live, and then 184 afterwards. So what it said to me is that we were able to manipulate the system a little bit, that we could move patients by ambulance so that they didn't come to the ED. We were able to reduce admits a little. And, I think that that's important. We have a regional system and the ability to actually manipulate the system when we need to. And it was hard, and we didn't do it as much as we had hoped, but I think we did it in a significant way. And that, to me, is important. And we will do the same for all the other sites that go live to help reduce the cognitive load on physicians and increase patient safety. In terms of metrics about, in terms of performance in the ED, so this is the median time to physician, minutes, and there's a timeline that starts in April of 2017, and you really can't tell where we went live. This is where we went live, and actually, we're probably down a little bit in terms of the average time to physician. If you look at the percentage of left without being seen, you can see where we went live. And there was a little uptick in that from about 1.6% to 2.7%, and I have that graphically represented here. So the left without being seen rate in the previous year was 1.2%. In the month before go live, 1.6%, went up to 2.8%, and then down a little bit to 2.7%. So that's significant. I mean, it's probably one more patient a day. I'm assuming over the course of the next year that'll smooth out. In terms of time to physician, you can see we were around 57 minutes at go live, and now at 56 minutes. And this is, compares favorably to what was experienced at Lionsgate in the year before. And then total ED length of stay, you can see that in the year before, 233 minutes had gone up to 299 minutes on average in the month just before go live. Around the time we went live, 234 minutes, and I think that reflected, no one needing to wait in the ED when they were admitted, that kind of thing. And then even after go live, 270 minutes is still less than the pre-go live value. So overall length of stay in the department was actually decreased compared to just before the start of the implementation. This data actually comes from a tool that Cerner has called Advance, and it's basically a keystroke logger that kind of shows how much time you spend in the chart, and there's an algorithm, like if you don't move the mouse in 30 seconds, the timer goes off. If you don't click a key, it stops counting. And basically, you can see that in the first month, this is just a sample of physicians. Actually, it's the slowest few and the kind of the fastest few. There are 30, but I didn't want to put them all on the graph. And you can see that there's broad variability in range and time that people are spending in the charts, and that over the course of a few months, that variability narrows, and that the average time in the chart, is somewhere around 10 minutes. Well, it's actually, it's around 10 minutes overall. And you can see that some people who were very quick to begin with, they got a little bit better, and some people got a whole lot better. But in general, you can see that a trend that people improve. I think this is one of the final kind of data points. So try to look at patients per hour. And this is tricky because the system, what would have been ideal was to take Dr. X and compare him, before and compare to Dr. X afterwards. But couldn't really do that because the way the data was captured in McKesson before didn't allow us to really know which physician saw which patient. It's confusing and a sad story, but for years we really couldn't tell what physicians did at Lionsgate. What I did do is I kind of looked at the total number of hours in the department and divided, the number of patients seen in a day by the total number of hours, and kind of got an average of patients. So at baseline, so in the month before, about 2.1 patients per hour. At go live, because of the extra resources and things, 1.6 patients per hour. So that means that if there's, if you're working 8 hours, I mean, you're only seeing on average about 10 patients, right? You are really, and that's important. You get slow, and you should be slow so you can ask questions of the elbow support around you. How do you do this? What happens if I do this? It makes it a lot easier. But over time, and what I've shown here is this 30%, 20%, 10%, that represents the amount of extra staffing. And then these blue lines represent the volume, which is, if anything, has gone up a little bit. And then you can see that after the support was done and after the 8-week mark, that we're at the same number of patients per hour, maybe a little bit better. And that, informally, when I ask physicians, no one is staying oodles of time after the shift to get the work done, because that was one of the concerns. Sure, the patients all get seen, but patients are staying way longer, and that doesn't appear to be happening. So that's the kind of the stuff we did to support physicians and to kind of keep the volumes under control. But the real secret sauce is, and it sounds kind of trite and silly, are these three things. Local leadership is so important, and that is both at the COO level and the senior medical directors at Lionsgate, Karen Olson, Peter Edmonds, and Ross Brown. They were awesome. Stu, who is here, did a fantastic job as the department head, and really got behind this, was involved, and that's what is really required. And there were Stu had some other helpers. There was Hazel Park and James Kung and Dave Pledger and Graham Gallons and others, I'm sure, who I'm forgetting. A core group in the department got behind this. They wanted demos. They organized things for their group. They went through workflows to make sure that when we went live, the orders were as good as they could be. The workflows were as tight as they could be. And yeah, there were tons of things that we found after, but these guys really invested the time and energy. You have to invest the time and energy at some point. Either you do it before, when you can drink a beer and talk about it, or you do it after, when the whole place is on fire. And so it's much easier to do it before. Engagement, that's really important too. And we met regularly with the Lionsgate emergency physicians. We went to their meetings. We had rounds. There were demos. Again, that kind of stuff is really important. People need to feel, even now we have a system built, but we are going to need to tweak it slightly for each of the subsequent sites, and those sites need to feel that they're being listened to, that their voice is important, that the system is for them, not just some nebulous enterprise build thing. And then the last thing is this responsive design. So, as I said, we just took all the American out of it. And then as well, these EHRs are like a Clint Eastwood movie, the good, the bad, and the ugly. I'm a real Clint Eastwood fan. When I can't sleep at night, I usually watch one of his old movies. Somehow him shooting people makes me feel better. But the good is celebrated, and it makes people smile when they use the system. The bad can be reconfigured. There's a workaround, a fix. You work hard to make the bad good. And then there is just the ugly, the Cerner functionality that you wonder, why is it the way it is? It's hard-coded, can't be changed. And the answer to that is to add more good, either other apps or other software enhancements, whatever. You do your best. And that way, even though people get peeved about the kind of splinter in their finger kind of thing that is the ugly, it's overcome by some of the good. And we tried very hard to implement as much of that as we could, and there'll be more of that rolls out at St. Paul's, and VGH St. Paul's already has a system that has some other functionality. The good news is the rising tide raises all boats. When we move into St. Paul's, if there's other functionality that's added, it goes everywhere. It goes back to Lionsgate and to the other sites, and that's important too. So those things are really critical. So the naysayers among you are going to point out that Lionsgate had a pre-existing system, and it wasn't really a great one anyway. And so if all we've done is show that we are as good as it was, what are we showing? It's just one site. Their staff was already used to electronic health records, so really, what have you demonstrated? And I think that I'm going to let Stu say a few words about the implementation and the impact of the change. I guess I would say it's still damn hard, no matter what you do. And the other thing that I would say, and because Squamish, their go live has gone well as well, but one of the things that you realize is that you have to use it to get good. If you're a family doctor, for example, who works in Squamish, and you do 2 or 3 shifts a month, it's going to take you a really long time to get facile with the system, and that valley of despair is a really long time. It can take up to a year. When we talk to people in Ingersoll, Ontario, who also implemented Cerner, a similar kind of 23-bed hospital, they also noted a long time before they got better. And so one of the benefits of upstaffing is you can get everybody to work more in a concentrated time. It doesn't happen in the ED, but in the places like the ICU where they do a shift, like a week's worth of shifts, we ask them to do like 4 days worth of shifts and hand over quickly so that everybody could get used to the system early on. So I don't know if you want to come up and say a few words or talk for a minute. I know I put you on the spot a little bit.
Thanks, Eric. For those who don't know me, Stu Horak, I'm the department head at Lionsgate. I guess I'm here to say that we are now through the valley of despair at Lionsgate. We definitely hit that low point. We're now 4 months in, and I think on your slide you had people that were moving forward. We have a few of those. We have the majority of the group who's accepted it, and there are still a few people who are hostile to the system, but they're moving in the right direction. I don't think there's any one particular. It was the combination of all those strategies that made it successful. So ambulance diversion, all the training, the upstaffing was key. And I think the graph that you showed with our efficiency, I think that's accurate. I think we're pretty close to where we were before go live. So I don't think people are staying really late after their shifts. I think we're seeing the same number of patients per hour that we were before. So I think all in all, fairly successful. I think there are definitely, it's all those little things, you talked about the pinpricks. Yeah. So it's those little things that are really pissing people off right now, and we're trying to slowly improve those, but those are all relatively minor. They're small details that some can be fixed, some can't. And it definitely, it's similar to our previous EMR. It's the younger members of our group who they have no problem. Some of them actually really like the system. It's the older folks in the group like myself who are struggling with it more, but we're slowly catching up. Yeah, what else to say? Anybody has any questions? Steve.
So as a skeptic, I'd like to commend the two of you, and especially Eric, for his hard work on mitigation, because I think that's critical for these things to work. I had a couple of questions. One is, what's the plan for new staff that come in who are new hires or locums? So that's one question. And the other question I have is related to evolution of the system, and how much support is there for evolution of the system as new things come forward, or a group decides they need to make a change? Okay,
so you've hit on some very important questions, and so one of the things we didn't talk about today was sustainment. That actually is just starting to roll out at Lionsgate. It was one of the things we were slow off the mark, but training will happen within your organization. And what is true is that people who come on won't be able to, do the Stenstrom and say, "Oh, Jesus, I'm here. My first shift starts in 5 minutes," or whatever. Sorry to pick on Rob, but he's shown pictures of me doing odd things to a sheep, or whatever. When we have new locums, when we have new hires, when we have residents, there has to be a very important strategy, a very deliberate strategy, the word I'm looking for, onto training them, and elbow support, people who follow them around even though they are new. Now, that hasn't happened at Lionsgate for all of your new people, but it needs to happen. The other thing that you're asking about is a really important point, and I think as well. And what I would say is that we are all used to having our electronic health records laid siege to for 10 years, like nothing, just watch it kind of crumble into the ground with, punctuated by the odd code gray, silver, whatever, where you pull your hair out because you can't look up anything. And that's not the model going forward. This is a huge investment by the organization that this is the way we will do business in the future. There is going to be constant upgrades and changes, and this idea that this is all we're getting and we're not going to get anything else ever again, that's not the way we will do business. We have regular code upgrades now every 2 weeks, not code upgrades, but packages, changes, order sets, whatever, and that'll carry on forever. So, there is a regional ED kind of working group that vets requests for change. So it'll function more or less the way things function now operationally. If things only affect other groups in your organization, the workflow between ICU and yourself, for example, and doesn't have any impact anywhere, that will be a change that you make inside your own organization. If it has broad impact to how other emergency physicians will work, then it'll work its way up through this regional group. A lot of the focus was on Lionsgate. Human beings are smart. They only focus on the problem that's right in front of them. So for places like Richmond and VGH, where, a couple of years ago, this was just some, distant hurricane coming, they didn't have to worry about it. But there is room for people who have interested, and we have made sure that we have representation from all the sites.
There's a question online. 17 people signed in from their own private computers. 45 people like that.
That's 45 more than I was expecting.
Is dictation enabled now, and what would be about?
Yeah. Why don't you answer that?
Can I repeat the question too?
Yeah, so the question was, is dictation enabled? Yes, it is. In fact, we started it at least 6 months, if not a year, before we went go live, which I think was key. It works very well, very easy to learn, but not to have to learn that at go live was a big help. So definitely suggest learn it early, learn it before you go live, so that at least that isn't a hurdle. You're familiar with that component at go live.
I am going to try a technical sleight of hand here, and I've logged in remotely to Cerner. One of the benefits of the new go live is that you can do work from home. So if you have to take the kids to ballet and you can't finish your charts, you can do them at night. I think that's really helpful. It's really helpful for people who are on call and the nurse calls about a patient, you can enter the orders. I have on my phone the microphone app for Professor, front-end speech recognition. I'm just going to make this bigger. So this 24-year-old male presents with nausea and vomiting, period. It picked up something I said before. So you can use your phone to dictate. You can also insert macros, insert normal physical exam. remove all fields. So it takes away all, you can go next field and add things, or you can just remove all the brackets, and there's your, if that's your physical exam and that's what you want to do, you can do that. And then one of the things that's important about documentation is that this is called dynamic documentation. You'll notice at the top now, this is a demo patient, but the vital signs would appear there. When you go to create your note, it brings in lab results, imaging results, the nursing vitals and things, and it creates your note for you. Now, there are lots of problems with the note and how it works that you will learn and sort out. But basically, you create your note, and it's the documentation is actually one of the good parts of the system, and the front end speech is incredibly helpful. And that was a lot of fighting to get that in, but I think it's helpful, and I think people like it. Ria?
Really interesting presentation, thanks. And it's cool to have you here, Stu, to give perspective from Lionsgate. And I got to say, that is pretty cool to see you dictating and stuff popping up. I mean, I've been a little bit of a skeptic around the front-end speech stuff, partly because what we're using now isn't really optimized, but that looks amazing. My question is kind of on unintended consequences. It's kind of a positive spin on that. I'll sort of offset your skeptic thing and ask about maybe a positive unintended consequence. I was kind of intrigued that you were able to convince the ambulance system to ask questions up front to direct where patients go. And as you know, that's forever a thorn in the side of a lot of institutions around here where someone's just been discharged and then they show up somewhere else. Do you think there's an opportunity here as this rolls out and the ambulance gets attuned to the concept that they can help influence the system, that maybe we can upfront have something like that so that we have better allocation and distribution of patients and the system can react to it? Because up till now, it seems to be that they kind of do whatever they want.
So, yeah, that's a really good comment, Riyadh. And the truth of the matter is, in my regional ED role, we've been working at this forever. I think that in terms of diversion, the thing that worked best was the coastal, I didn't talk about this, but, Pemberton, Sechelt, Whistler, Powell River, Bella Coola, and they refer patients to Lionsgate. They're the referral center. So we could work with PTN and say, and the staff and there was a lot of work that had to go on to get everybody's agreement, but we could say, when they called PTN and they had to call PTN would say, you have to go to another hospital. You have to go to Lionsgate, or you can't go to Lionsgate. And that was about 1 to 2 admissions a day, maybe a couple of few ambulances. So that worked a lot better. To be honest, the person in charge of the ambulance, we had daily calls to say, we want, how's it going? And like one of the first days, there was no change in the ambulance volume. And I think the comment was, well, you didn't really think we were going to do that, did you? I mean, it was shocking. And, we're needed in the North Shore and blah, blah, blah. And, so there's a long way to go. Now, that person has since moved out of the role, and there's yet another person. And it'll be a little easier in Vancouver. Admittedly, it's hard to get people from the North Shore, and people from West Van don't want to go to St. Paul's or MSJ or VGH. They want to go to their own hospital, and we learned that when we did when we started the ED wait times website. We were concerned that there would be this lemming effect where people would just when it was quiet at one place, everybody would go to that place. And when we asked people, like 85% of them said, nah, it's the 7-Eleven thing. I'm going to the closest place. I'm going to my place. They know me. So it's pretty hard to move people around, except where you have a lot of choice, except when you're in pain, except when you're young. Those people will move around more. So there's probably more opportunity to engage the ambulance But yeah, it's a real challenge to get the ambulance to do stuff.
Just one follow-up thing would be, I mean, I'd still encourage you to try and capitalize on this opportunity. Like, in my mind, people don't get to choose where they go. It's like when they call for a rescue. They don't know if it's North Shore Rescue or Lions Rescue when they're on the mountains. They're calling for a rescue. If you call for an ambulance, you shouldn't get to pick where you go. And I think there's an opportunity here if we can kind of continue to encourage culture change. I mean, you're doing it here on the physician end, and I think you're doing a great job of it. And, I think there's a shift, and we're seeing it. The culture is changing. Let's encourage it on the pre-hospital end as well. They're part of the system. They don't get to act in a renegade way. I don't get to be a renegade, so why should they, right?
I agree. Thank you. You've inspired me. I'm going to go forward and do more. Ross.
Eric, I think you're actually the foresight to do I guess I got a couple questions. When you're going to go live with this, is this going to be all of Vancouver Coastal with the exception of line response? You're going to go live through at the same time?
No, there's a rollout sequence. So the next sites that are going live, so this is not just Vancouver Coastal and Province Healthcare, it's also PHSA. So the Cancer Agency is going to roll out, and they're very tricky because they have Abbotsford, Prince George, Surrey, the island, Vancouver. And so they are going to roll out next spring. We're going to do a code upgrade, which will make the system faster. You'll be happy about that. And then we'll roll out to Province Healthcare, and then how VGH, UBC, and Richmond will roll out after that is not entirely clear. And the Children's Hospital will probably roll out roughly the same time. So ideally, everybody will be done by the end of 2020. Okay. So maybe so will I.
Now, the second question is, this sounds self-serving. Do you anticipate any differences in those implementation curves and learning curves that
Yeah. So that's a very insightful question, and I think that we're working with the PHC, with the St. Paul's group, and we're going to, within the guardrails of patient safety, like not allowing wait times to balloon, and providing physician support. Like, what was my other guardrail? Yeah, allowing physicians time to learn the system, right? So that fee-for-service is tricky with that part, but within these two guardrails, we're going to work with PHC and the St. Paul's group to let them kind of choose the model that they think supports them. Out of the gate, there are some ideas that I think will work okay, but it is true that there will be a small hit. I mean, if we reduce ambulances a little bit and all else remains the same, there'll be slightly less volume. But that's for 2 weeks. And the fact is that it affects all physicians, not just emergency physicians. And I have to believe that in the end, if you invest the time up front to learn the system and get comfortable with it cognitively, that you will in the end be a strong biller. It'll work out for you, and you'll be as good or maybe better. Who knows? But it's a good question. Anything else? Any other comments?
Eric, one other thing. Is Cerner affiliated with TELUS? Does TELUS think you can
They are not. No. Yeah, are there any questions from any of the other sites? Wave. Give me the finger.
Eric, thank you so much. And Stu, thanks for pitching with him and assisting. It's interesting times, and this is the guy who knows more about this sort of stuff than anybody. So, Eric, thank you very, very much. It's a great start off the academic year. And I will shift into St. Paul's Grand Rounds.